Hello everyone, hope you all are doing good and taking good care of your mental health. I'm Limpee Kalita, psychologist from Kolkata. In previous video, I have discussed about the mental status examination and the history taking, but it is I give just general idea what it is in the reality. Okay, I didn't discuss about the theoretical part. So today I'll be discussing the theoretical part because if you are a beginner and if your interview is taken by a psychiatrist, so they will definitely ask you the question from the mental status examination. I know you all are very excited to know about the counseling processes, how you will be resolving the cases. If you know the mental status examination very clearly, if you understand the client, if you understand the history taking, okay, then no, you don't actually need anyone's help. In previous video, I have shared the format of the history taking and mental status examination. Today I'll point out some of the important point from the history taking and mental status examination, which is very important to decide what will be your treatment plan, which technique you will be going to apply. Okay, so be attentive. So first point in the history taking is the identification data. So there you know the socio-demographic data you will be collecting in that. I have shared the format, you can see it, there is nothing to explain actually. In the psychiatric history taking and mental status examination, informant is the important part because most of the client doesn't have insight. Okay, so for that purpose informant is the important. So informant should be a close one. Okay, it may be husband or wife or parents, okay, or children, so who is mostly close to the in the field of psychiatry we call patient, but in the field of psychology we call client. Why? Because it doesn't necessary that everyone coming for counseling they must have any psychological disorder, right? So that's why we call client. In the present complaints or the in chief complaints, you have to write it 2 column, okay, according to the client and according to the informant. 2 column you will be writing, and the name only you can see that the chief complaint or presenting complaint means at present when the client is coming, the problem is having since 2 years or 3 years, right? But since 2 years 3 years they are not coming, means they are managing somehow, right? So at present there must be some chief means major complaints, right? What because of what they are actually coming. Okay, so you specifically ask them if they are not able to explain what in the present client is suffering, what brings you here at present, what was the problem you are having or your patient or your client is having, your father or son is having, because of which you thought that he or she must be admitted here. Okay, if you ask that specific question, then they will be clear. From here also you will be know about the insight of the client. Okay, how? So sometimes what happened, the patient if with psychotic symptom, they will say no, I don't have anything, I don't have any problem, they will completely deny. Okay, so from here you know about the grade of insight. Other than this, some important points are like onset of the present illness or symptom, so it can be acute or gradual. Okay, then second one is the duration of the illness, since when it is having 1 week, 2 week, 3 days, 4 days, 1 month, 2 months. Okay, or in some cases if it is in a continuous, okay, if it is not episodic, continuous, then it can be like 1 year. Then course of symptoms or illness, so course can be the episodic or the continuous. Okay, if in the past they had 1 year back, then they got relief, then again then they relapse. Okay, so then it will be the episodic. Complaints are having continuously since 1 year or 2 year, okay, not any gap in between, or not they went to any doctor or psychiatrist. So if then it will be continuous. Okay, then coming to the predisposing factor. So in the predisposing factor you can know write about the family history. Okay, genetic history is positive, there is history of suicide, there are any history of the maternal side or the paternal side, about the psychiatric history that can be written. Or any if you go into the childhood of the client, if since the childhood only the client had any low esteem, okay, in such point you can be add in the predisposing factor, means risk factor. What are the risk factor already present in the client, that will be added in the predisposing factor. Then in the precipitating factor, what is happening in the present situation. Okay, so they are having a risk factor of genetic history like low self-esteem in the client, right? After that they are having any problem in the office, in the financial issue, in the family conflict. Okay, so in those area if any problems are arising, any factor are arising, so that will be the life stressor any present, so it will be called as the precipitating factor. Precipitating factor will increase the chances of occurability, means environmental factor you can also call as. Precipitating factor is important to identify or to plan out the treatment technique. Last point is the relieving factor or perpetuating factor. So what does it mean? Means any factor which resolve the client's problems, okay, whatever the symptoms are having without any medical help. Is there any environmental factor which is helping to relieve or resolve the problems? Like this can be any loved one which whom they can share the problem and they can be relieved, okay. And also some people, like if they're busy with their work, if someone read the present history of illness, they will be clear about the case, what is actually happening to the client. Here you can see it in the screen. I've written this long back ago, actually during my internship after the masters. I didn't mention here the age, actually I had to mention the age also, okay. So you can write like Mr. so and so, a 50 years male, was apparently well before 1 year ago, that is I've written March 2020, when his son-in-law died in an accident at young age, which was very miserable event for him. So here you can see the life stressor or the precipitating factor is the death of his son-in-law, right. After the accident, some changes of behavior noted by his family member, okay. At present, since 3 months, he has developed sadness of mood, which is associated with the irritability, okay. He sits alone most of the time with sad facial expression and doesn't talk to anyone, but previously he played with grandson, spent quality of time in conversation with the family members. He was not performing daily activities like not maintaining personal care, as he used to take to bath at early morning. So you can see there changes in his behavior. Whatever activity he was doing in the past, at the present he is not doing those activities. So one symptom you can find from this here, lack of interest in this activity, right. He is not taking food properly, as he before used to take 3 meals, but after illness only 2 times, but in very low quantity. He participated in the religious song programs, composed music, but at present he is completely abstinent from these activities which were previously pleasurable. As a result of guilt, as he is unable to bring happiness in her daughter's life after the death of his son-in-law, he developed feeling of hopelessness, helplessness, worthless, which leads to when often having suicidal thoughts, although there was no attempt so far. Mr. XY further stated about decreased sleep at night due to those negative thoughts. Previously, he used to sleep 8 hours regularly, and it decreases to 4 hours. So you can see here I have mentioned I have explained the symptoms in detail, right. So what was previously and what is the present. So in the present history of illness, you should use the layman language, okay. You can't use the psychiatric term or the psychological term, and same it is with the chief complaint also. According to the client's word, the informant's word, you have to write it. And here you should, important things should include the sleep pattern, okay, eating pattern, okay, and their activity. Those points should be included in the present history of illness, you can see. So from here it is clear, since when the problem started, I just have mentioned from here only. So in this screen you can see the alcohol and substance abuse history. There will be the case questionnaire, it is called. First point is the cut down. Have you ever felt the need to cut down on your drinking, okay. So if client is thinking, okay, I should cut down from the alcohol, so there must be problem arising because of his substance, right. So there must be unmanageability which indicate. So if he say yes, okay, I thought I should cut down, if that thought comes to their mind, you can add point 1, okay. Then annoyed, have any people annoyed you by criticizing drinking or substance abuse. So if it is unmanageable, okay, if it is harming, it is procurating problem, then obviously family member must be complaining, okay, why you are drinking. So family member must have asked them to cut down from it, okay. Then third point is the guilty. Have you ever felt bad or guilt about your drinking or substance? So if it is creating problem, if there is loss in the money, if there is occupational dysfunction, family dysfunction, social dysfunction, so sometimes they must be feel guilty, okay. So if it is yes, then you can point 1, okay. Then after that, eye opener, okay. Have you ever had a drink substance abuse first thing in the morning? So you can ask like is it happened that just after wake up, or in the very first thing you had drink or your substance in the early morning? So in case of the mainly whoever are cannabis abuse clients, so they actually use in the early morning, and also the alcoholic also, okay, and in the brown sugar addict also, so they use it very early, actually early morning. So after all this question also you can ask the history, like first cause of the consumption, okay, when the first time started, time duration, okay, when the first he started. Then if you identify the cause, here I have written curiosity of, it is a history of one client actually. So sometimes it can be the breakup, it can be the death of someone. Okay, then initial and present drug. Okay, so DOC, drug of choice, you have to write it down. Then history of tolerance. So how you'll be asking the tolerance? You'll be asking, okay, so at the very first time, what kind of what amount you taken, and at the present, what is the amount you are taking? Okay, that will be the tolerance. If the amount is increasing, if he took alcohol, 60 ml of alcohol at the very first time, but currently, or the maximum he had taken is the like 180 ml, then tolerance level is present. Then craving. So how you're asking the craving? Okay, is there any event happen that, okay, you should feel, yes, I need it right now only, I can't live with this? If such thought is happening in your mind, then craving will be present. Like you can ask, okay, is there happen that because of your substance abuse, you didn't go to your work, or you didn't go to any social activity, or you are not taking care of yourself or your family? So there is craving present. Then loss of control. After drinking, if they are like become unconscious, or they become very violent, that they doesn't remember about all this thing. Okay, then it will be called as the loss of control. Then abstinent and withdrawal. So abstinent is the history of cut down. Okay, if the client by self tried to cut down from 1 week, 1 month, 2 days, then after that they again started drinking, and they cut down maybe because of the treatment, or because of his self will. Okay, because of any family pressure. So along with that, you have to write the cause of the abstinent also. Okay, then withdrawals are those symptoms when the client stop use his drug or the substance. After that, they face some symptoms. Okay, so according to the substance, there are different withdrawal symptoms. Like I'll give example in case of the brown sugar. So they feel very severe body ache. Okay, so it is the symptoms of the opioid use disorder. In case of the opioid use, so they will feel tear coming. Okay, then running nose. Okay, headache, weakness. Okay, and in case of the alcohol, they will having nausea feeling. Okay, so according to the different drug, different substance, there are different withdrawal symptoms. So withdrawal symptoms are those who after use of long time, then they will just suddenly cut down from the substance, then they have some symptoms. Okay, those are called withdrawal symptoms. So if the withdrawal symptoms are present, then it indicates that client is dependent on that drug. Because of dependency only, withdrawal symptoms will be presenting. Okay, then maintaining factor. So in case of this client, maintaining factor was the craving. Okay, so in case of this, there must be a stressing factor. Maintaining factor means, so why client is not cut down till now. After the abstinent also, why client is started using. Okay, that can be the maintaining factor because of which the client is still continuing the drug. Then locus of control. So it can be the external or the internal to use the drug. Okay, how you identify this? You will be asking the question, you are using it alone or with the group. If you are alone, if you are in your room, if there is no substance, no friends, then also you'll be using the drug. If they say yes, so it will be internal. Okay, so if always the client is under the influence of the friends or any other person, external cause, then it will be the external motivation or locus of control. And next point is the salience. Okay, salience is the person want to cut down, okay, but they can't. Okay, so there is two thought in their mind. Okay, so in the same time, they doesn't want to take the drugs, but they have the desire to. Okay, so there is when conflict in between their mind, so there is presence of the salience. So mostly it can be seen in the recovering addict. Okay, who had cut down from the alcohol, they are in a recovery period, and the time they have this thought. Okay, if they are unable to handle this, then they will be relapse. So this was the alcohol and substance abuse history. Then coming to the mental status examination, general appearance. Okay, the outer look of the client. The first point is the level of conscious. So mostly client actually they're conscious, but in some client you can say they are confused. Okay, by their facial expression you can see they are confused. So it happens actually mostly in the case of the psychotic patient, or if they are intoxicated, if they are in the withdrawal stage, then they will see you will see that they are in confused state. Okay, bodybuilding, you can check the weight. Okay, and grooming, if client is having depression or any psychotic symptom, then you will see the grooming, they will be not well groomed. Okay, they are not maintaining personal hygiene, but grooming is very important in case of the manic patients. Okay, you will see they are highly actually highly grooming. Okay, if they are coming in to clinic or in a hospital, so they shouldn't wear high heavy makeup. Okay, you can see they are wearing goggles, they are wearing very heavy jewelry. Okay, so in such kind you can see manic patient, you can see in the grooming is very important in case of the manic patient. Okay, so in the cooperativeness, so in case of the client who will have insight, they will be cooperative. Okay, so if the client is not cooperative, you can see that there is lack of insight. This is also important point for to identify the insight. And also you'll uncooperativeness you will see in the alcoholic patient or any psychotic patient. Okay, in the manic patient they will very argumentative with you. Okay, so you have to be take care of that. Then gait and posture. Okay, in gait and posture, like abnormal gait and posture you will find in the alcohol. Okay, it is called tandem gait. In tandem gait, what you actually do, you ask the client to walk in a straight line. Okay, if client is not able to walk in that straight line, then it will be you will say that gait and posture is not normal. It is called tandem gait. Okay, in case of the neurological examination it is done actually. Psychomotor activity, you can write it down: increase. Psychomotor rigidity you can see, or it can be decrease. Okay, in case of the manic patient or in case of the bipolar patient it can be increased. Okay, but in case of the schizophrenia patient you can say rigidity. Okay, rigidity in their hand movement, leg movement. Okay, they are very stiff, you can see. And in case of the depressive patient you can see their psychomotor activity decrease. Okay, and in alcoholic patient, substance abuse patient, you will see like in some patient decrease, or in some patient actually increase. And actually just during the withdrawal they will be highly increased psychomotor activity. Social manner and non-verbal manner. Here you can see maintain eye contact properly. Okay, so you can say that okay, eye contact, maintenance of the eye contact you will note it here. Okay, if client is not maintaining eye contact, that one big cause for uncomfortability, nervousness, anxiousness. Client may have low self-esteem. Okay, in the first day if your client is not comfortable with you, then also, and if it is due to in case of depressive patient or in case of schizophrenia patient, they won't maintain eye contact. Okay, in case of the manic patient also, they will look around the room also. Okay, they also may not maintain. Okay, an irrelevant smile, you will find it in the manic patient. An irrelevant smile actually you indicate the presence of hallucination. Okay, so if you have to look into it, is there history of hallucination or not, by asking. Okay, you can hear voice, I'll discuss it in later on. Rapport established, you can say it is established or not established. If client is cooperative with you, then definitely it will be established. Speech, you can see the rate and quantity of the speech. Okay, so in case of the depression patient, some patient you can see the mutism, means they are not speaking at all. Okay, if it is spontaneous, okay, normal in productivity, whatever you are asking they are answering that only. Okay, so then it will be like normal. It is spontaneous, productivity is normal, you like write like that only. Okay, then rate is the rapid or slow. Okay, again in case of the manic patient, in case of this bipolar patient, then it will be the rapid. Okay, rate is the rapid, or in case of the depression it will be slow. Then pressure of speech or poverty of speech. So again in case of the bipolar or mania, there will be the pressure of speech, or in case of the schizophrenia, okay, in case of the depression, then it will be the poverty of speech. Volume and tone of this speech, you can write increase, it is decrease, or it is appropriate or not pitch. So you can observing by looking or listening, you can identify this. Flow and rhythm of speech. Okay, so in the flow of freedom of speech, what happens, and mostly in the normal case it is smoothly client is answering, like. Okay, so if blocking, suddenly if client is topic, okay, there is presence of the blocking. Presence of verbalization. In the verbalization, like they will randomly repeat any word, okay, which doesn't any word, it can may have meaning or not meaning. Okay, and also there's one thing, neologism, so they will create new word actually. Okay, and they will repeat that, so that is called neologism. Flight of ideas, so they will shift from one topic to different topic very randomly. The clang association, what that client will do, so in their speech, what they are talking, there is no logic actually, just to maintain the rhythm, rhyme. Okay, just to maintain the tone, sound, they will create any sentence. You can say this, read this sentence in the screen, you will understand. Circumstantiality and tangentiality, what is the difference between this? In this circumstantiality, you will be asking the question to him, okay, what did you have in the breakfast? So you will be talking about so many things, I did this, I did that. Then after that, at last they will coming, okay, I had this in the breakfast. And the tangentiality, if you ask something, okay, they will change the topic to something else. Okay, they never answer what you actually asked them. Okay, so mood, it is what client is saying, how are they are feeling, and the affect what you observe actually. Okay, observe their expression at that time. So if that is not match, you will write like mood and affect is incongruent. In case of the manic patient, okay, you will say euphoria, elation, exhalation, ecstasy. In case of the mania. And in case of the depression patient, you will say the anxiousness, restlessness, anxiety, sadness, irritability, anger. Then coming to the thought process. So if thought process is normal, okay, if they are talking about their problems openly, if they are interested in the treatment process, if they are asking how it can resolve, okay, in the last client, you can say that she was taking initiative, right? She was doing meditation, okay, she tried to watch the videos. So putting some effort. So which means he is goal directed. Goal directed means what is the goal? Goal is to resolve the issues, right? So client is motivated to resolve their issues. So that means client is goal directed. Okay. So in case of the psychotic symptoms, in case of those neurotic symptoms, okay. So in case of the neurotic symptoms also client can be goal directed. Okay. But in case of the psychotic symptoms, mostly they are not goal directed actually. In this thoughts, there are 2 points we actually write: stream and form of the thought and the content of the thought. In the stream or form of the thoughts, you will write the loosening of association. Okay. Irrational, okay, not goal directed. You can write all those things in the stream and form of the thought. So you can see in the speech we have written about the tangentiality, circumstantiality, right? So if there is tangentiality and circumstantiality, so obviously the client is not rational, it will be irrational. So there is presence of the illogical thinking, like, right? Then if it is client is shifting from one topic to different topic, then you can write it loosening of association. Okay. So there, if means there is no continuity. It is if it client is suddenly stopped, then thought block is present, right? So you will thought block is present, so there is no continuity in the thought process. So thoughts and speech both are actually connected. If there is problem in this speech, then there must be problem in the thought process. You have to note it. Content of thought. So first, like point is the obsession, any preoccupation. So obsession, if there is obsession present, so it will be identified as the OCD, right? Obsessive compulsive disorder. So here one point you have to note it down: obsessive compulsive disorder and obsessive compulsive personality disorder. Ego dystonic or ego estonic. Okay. Ego dystonic means when the client is having all those thoughts, all those irrational thoughts, so client is actually not comfortable with that. Client is irritable, disturbing because of the thought. So then it will be the obsessive compulsive disorder. Okay. But they actually become the perfectionist, right? So they also spend a long time in one activity, but it doesn't actually be affected, right? The other people are affected, but they actually doesn't affected by that. The delusion of infidelity, when the partner actually is very suspicious about trustability. Okay, the partner may have extramarital affair. Okay, so in reality which is not. So for this type of confirmation, you need the very reliable informant. Okay. Then nihilism. So within this delusion of nihilism, what happened? The client think that their any internal organ is destroyed. Okay, any internal organ has not present actually. Okay, in such case it is called nihilism. Then delusion of love is also present, so it is called erotomania. So client think that okay, some very highly influenced person, any hero or movie heroine, okay, so they are in love with them. Okay. Other than this, like delusion of control. Okay, client think that someone is controlling him. Okay, whatever he is saying or whatever he is doing, so he think that okay, I'm not doing anything, so they are controlling me. Okay. Then thought insertion. Okay, so they think delusion of thought insertion, they will think that okay, people is someone is outside from giving me those thoughts. These are not my thoughts. These thoughts are coming because someone inserted in my mind. Then thought withdrawal. So here client will tell you okay, my thought someone is taking out my thoughts. Okay. In case of this schizophrenia patient, all these are delusion of control, there is a thought insertion, thought withdrawal, and thought broadcasting. So these are called as the first rank symptoms in case of this schizophrenia patient. So in the thought broadcasting, what happened? The client think that whatever they are thinking, you can listen to that. Okay, client will think that, client will say that okay, whatever I'm thinking, you can guess that, you can know. Perception will come the hallucination and illusion. Actually illusion already you know, misperception actually it is. Hallucination is important. So already I told you the hallucinatory behavior you can see in the general appearance only. Client will smiling irrelevantly, client will speaking मतलब मुंह के अंदर ही बात कर रहे हैं, बड़बड़ा रहे हैं, है ना. The client is not properly speaking to you, but something is saying inside only. Okay, so then it will there is presence of the hallucination. There might be presence of auditory and visual hallucination. So already you know auditory visual hallucination, you can ask the person okay, can you hear any voice? Okay. Or in case of the audio visual hallucination, like if client is saying that okay, I can see those god, I can talk to them, okay, I can see them, so that is visual hallucination. Except that auditory and visual hallucination, there must be olfactory hallucination, gustatory hallucination, tactile hallucination. Tactile hallucination, client will say okay, something is crawling over my body. Okay, they get this sensation actually. Okay. Insight. Okay, insight, if you write, you have to write about the insight. You have to write down like grade 1, grade 2, grade 3, grade 4, grade 5, and grade 6. So first one is the grade 1, when client will completely deny. In case of the mania patient, in case of the schizophrenia patient, they will say I don't have any problem. But in case of the 2 point grade 2, slight awareness of being sick and needing help but denying at the same time. Okay, in patient will say हाँ कुछ problem तो हुआ है मुझे, इसलिए मैं यहाँ पे हूँ, फिर सेम टाइम पे उसी टाइम ही बोलेगा कि नो आई डोंट हैव प्रॉब्लम, एनी प्रॉब्लम, ओके, शायद ऐसे ही आए हैं, तो दे वोंट बी, मतलब दे विल हैव ए कन्फ्यूज टू डायरेक्शनल स्टेटमेंट. Then third is the awareness of being sick, but it is attributed to external or physical factor. Okay, like in case of the alcoholic patient or the substance abuse patient, they mostly have actually grade 3, because if you will ask them, okay, why you are here, so they will say दोस्तों ने पिला दिया, दोस्तों की वजह से किया. So they, when there is blaming factor, so actually attributed to external factor, right? So it is awareness of big thing but attributed to some external factor. Then fourth one is awareness of big thing but due to some unknown to self. Okay, client will explain all the symptom to you, but at the same time they will say, if you ask so why all this happening, if you explore about the cause, so they will say I don't know about it. Okay, then fifth one is the intellectual insight, awareness of illness and that the symptoms or failures in the social judgment are due to their own particular irrational feeling thoughts, yet does not apply this knowledge to the current or future experience. So most of, in case of this relapse cases happen in the alcohol substance abuse, you can see, so they actually aware about what are the problems happening with them. Okay, why this is happening, because of their behavior, their drinking or taking substance abuse behavior, all this problem is happening in their life, but still they doesn't use this, right? But in but knowingly they are creating problem in their life. So it is called intellectual insight. Okay, last one is the true emotional insight. So here client is aware and they will try to change their future behavior. They actually know about the treatment process and all purely. Hope you all are clear about the mental status examination and the history taking part. I have mentioned the important points. Other than all these other points, you read it by yourself, you will understand. Okay, coming to the treatment part. Okay, so previous in the first case we have mentioned about that client was mainly depressive symptoms, we can see, right, that the client was not interested in doing daily activities. Client is not able to come out from the grieving. She is in a process of grieving process, right? So read about the stages of grief. Because of any psychiatric patient, they actually have very low energy. Okay, so because of the stressful event, they actually have muscle tension in their whole body. Okay, so they are not actually in a relaxation mode. So I always try to make comfortable, okay, make the client in a relaxable state. Okay, then only I go with other techniques. Okay, so in case of that previous client, so I actually applied JPMR, okay, Jacobson progressive muscle relaxation technique. So this way it is, I didn't use actually that properly one, I used the modified one. So I just wanted to make the relaxed client. Okay, for that purpose only I used. So you can see the video how it can be, you can be used within some time. It will take 10 minutes. Before just going to the session, I want you to be just relaxed. Okay, currently you are very tense, you are very anxious, right? You are not relaxed actually. So I just want to be relaxed. So before going to the session, I want you to teach some exercise. Okay, I will try to make it simple so that you can remember. Okay, so if you can't remember, we'll record this video. Okay, so I'll send it you. Okay, so this exercise will start from the leg. Okay, so from head to toe exercise actually this is. Okay, so first we'll be starting from the right leg. Okay, so for every exercise I will be counting from 1 to 10. Okay, so at home you can do like 1000 to 10,000. Okay, so the time will be maintained. Okay, so start with the right leg, do it like this, keep finger like this. Okay, so keep it like that only. 1 2 3 4 5 6 7 8 9 10. Flip it, same do with that leg. 1 2 3 4 5 6 7 8 9 10. Flip it. Okay, again right leg. Okay, do it like this. Yes, give pressure over your ankle. Yes, 1 2 3 4 5 6 7 8 9 10. Very good. Again left leg. Yes, right now I'm doing it fast. Okay, at home you have to make the time. Okay, 1 2 3 4 5 6 7 8 9 10. Very good. Leave it. Again the right leg. Okay, now you have to keep it straight. Okay, yes, 1 2 3 4, 5, 6, 7, 8, 9, 10. Lift it. Again left leg. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very good. You want to have water? Okay. So again the right leg, okay, you have to make it, lift it, okay, lift the right leg. Yes, you can give some support over here if you want to, okay. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very good. Again the left leg. Okay, are you comfortable? Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very good. Okay, so now we'll do exercise of abdomen. Okay, so we'll hold the muscle and pull inward. Okay, so you will hold it till the counting. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very good. Okay, now we'll do exercise of chest, okay, and the shoulder. Okay, you have to give pressure over your shoulder muscle. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very good. Okay, so now we'll do exercise of deep breathing. Okay, so you have to take breathe from nose and leave it from out. Okay, so when you will take inward, your shoulder will go up, then when you will release, it will be released. Okay, your abdomen and chest both should move upward. Okay, yes, breathe out, breathe in, breathe out. Do it very slowly. Very good. One more time. One more time. Okay, so at home you can do 10 times. Okay, and you can do this exercise with your husband. You can do it from the morning one time, and in the evening one time. Okay, when your husband come back from office, at that time you can have a cup of tea with him. Okay, and after conversation you can do it. Okay, and in morning also, before he goes to office, before that you can do it. Okay, so by doing this, your relationship with him also be good, right? So your relationship will also maintain with him. Okay, so now we'll do exercise of hand. Okay, first make fist of in the right hand. Okay, make it like that. Keep pressure over fist. Yes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Leave it. Again the left hand, same. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Leave it. Okay, again the right hand. Okay, make it like this. Give pressure over here. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Leave it. Okay, same do it at, yes, very good. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very good. Leave it. Okay, again with the right hand, make it like this. Give a pressure over here, your biceps muscle. Yes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Leave it. Again the left hand. Yes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very good. Leave it. Okay, are you comfortable? Are you tired?
No.
Is it relaxing for you? Okay. Okay, now we'll do exercise of neck. Okay, look up here like this. Yes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Leave it. Okay, now your chin will touch here. Okay, do it like this. Yes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very good. Leave it. Okay, now we'll do exercise of jaw muscle. Okay, keep pressure over here. Okay, like this. 1 2 3 4 5 6 7 8 9 10. Very good. Okay, now we'll do exercise of teeth. Okay, do it like this. Yes, 1 2 3 4 5 6 7 8 9 10. Leave it. Okay, now keep this two finger over here. Okay, make a stroke over here. Okay, yes, keep it like that. 1 2 3 4 5 6 7 8 9 10. Very good. Leave it. Okay, now we'll do exercise of eyebrows. Okay, keep it like this. Yes, give pressure over eye muscle. Okay, 1 2 3 4 5 6 7 8 9 10. Are you feeling sleepy?
No.
Okay, is it very relaxing or that you are feeling
Relaxing actually.
Okay, so now keep this finger over here. Okay, make circle. Okay, try to massage your facial muscle. Okay, this will help to relax your facial muscle. Make 5 stroke clockwise, then 5 stroke anti-clockwise.
5 stroke has done.
Yes,
I didn't count.
2 3 4 5. Very good. Okay, so this exercise you have to continue, okay, till the next session. Okay, so today I didn't go to change your thought process or anything because I wanted to be relaxed for you first. Okay, so after that I will try to change your thought process. Okay, so that you can be comfortable at home.
Thank you.
Hope you will practice it, because without practice it won't be effective actually. Just remember, if you want to be a counselor, okay, first all these techniques you should apply in yourself. Okay, there is no shortcut. Hope this was informative and you enjoy it. So like and subscribe. Okay, if you have any queries, please note down in the comment box. If you write down in the comment box, okay, other people will be also interactive and they will be also be encouraged. Okay, I don't mind if you write me personally in WhatsApp, so I don't mind about that, but it will be very appreciated, okay, if you write it down in the comment box. So hope you enjoyed this video. Thank you.